This conference will now be recorded.
On behalf of my department, I welcome you all in today's OSP clinical meeting, especially to our esteemed guests who traveled so far to reach this far-flung area and grace this occasion with their presence. So we formally start the proceeding of the meetings with recitation from the Holy Quran.
بسم الله الرحمن الرحيم القارعة ما القارعة وما أدراك ما القارعة يوم يكون الناس كالفراش المبثوث وتكون الجبال كالعهن المنفوش فأما من ثقلت موازينه فهو في عيشة راضية وأما من خفت موازينه فأمه هاوية وما أدراك ما هي نار حامية.
First of all, I like to invite General Secretary of Lahore Ophthalmological Society, Professor Dr. Nasir Chaudhary. Sir, please come here and formally start the proceedings of today's meeting.
बिस्मिल्लाहिर्रहमानिर्रहीम। सबसे पहले तो मैं बहुत माजरत हूँ अपनी वर्दी टीचर से। प्लीज एक्सेप्ट माई हार्टफेल्ट अपॉलजी। और दूसरा ये कि जो हमारी क्लिनिकल मीटिंग, ठीक है, एज रिगार्ड द क्लिनिकल मीटिंग जो रूटीन में, तो दिस इज इन फैक्ट प्राउड प्रिविलेज एंड heartening to be here, and I would like to extend my deep gratitude to Honorable and Worthy Professor Dr. Mia Shafiq Amin. He is one of the finest human beings. He has been principal of Gurki Medical College and head chairman department of ophthalmology, an exceptional teacher and surgeon. That is equally supported by esteemed and competent faculty, Professor Khalil, with a unique type of wit and humor he has. And then the young and competent faculty, Associate Professor Moin Bhatti, in fact, backbone of this institution, and Sania and other Vakar, Shahid Tarar Saab, and prestigious our worthy teachers, Professor Khalil Rana Saab, Professor Nadir Razi Saab, Professor Salim Akhtar Saab, and prestigious gathering from different institutions of Lahore. We are well aware of the fact that professional societies are believed to play a significant role in benevolence and professional grooming and upbringing of their members. So in this regard, we can see OSP Lahore has uplifted and promoted the research culture in the country through the introduction of high impactor PJO, then OREF, Ophthalmic Research and Education Forum, and then resident free papers. For the faculty development and continuous professional education, what OSP has done, we have introduced medical education sessions and leadership development program for the faculty development. And then we can have quiz, wet lab, simulation, live surgery for the residents and the consultants sitting in the remote peripheries. So in today's clinical meeting, these clinical meetings are in fact sort of formative assessment, which allows you to reflect your weakness. It provides and highlights your weakness, provide you feedback where actually you are, and then you can define these weaknesses in upcoming summative assessment. So in today's clinical meeting, as a tradition, because OSP Lahore has a tradition to award certificate, shield, and souvenirs to the top presenters. I would like to request my beloved teachers, Professor Salim Akhtar Saab, Professor Nazir Asi Saab, and Professor Khalid Rana Saab, they will serve as the role of judge. And for this, now I would like to invite Associate Professor Dr. Meen for further proceedings. Jazakallah.
Thank you so much, Nasir bhai. Your words of appreciation are really a token of heartwarming from us. And to formally start the meeting, the format is like that. We have the 4 clinical cases in the start, which will be presented by our PGRs. Then we have a guest lecture in which the head of department of cyber knife department, Dr. Aisha, she will tell us about radio surgery and the role of cyber knife in the treatment of cancer patients. Then we have a very brief visit to cyber knife department that will be followed by lunch in the cafeteria. So to start the first step, for first case presentation, I like to invite Dr. Halima Azam to please come here and start her case.
Assalamu alaikum. I am Dr. Halima Azam, FCPS trainee in Department of Ophthalmology. So the case that I would like to present is of a 15-year-old male who is a resident of Batapur, Lahore. He came to us with complaint of double vision for 4 days and drooping of right eyelid for 4 days. His past history revealed that the patient was in usual state of health 1 week back when he developed high-grade fever with severe temporal headache. It was followed by diplopia, drooping of the right eyelid and blurred vision after few days. Patient was diagnosed and treated in medical department as a case of pyogenic meningitis. Fever settled with treatment, but double vision and drooping persisted. And there was a history of fall from roof 11 years back that was associated with loss of consciousness for 10 minutes and blood-stained vomiting. Later on, he gained consciousness spontaneously without any apparent neurological deficit. On detailed probing into the past history, it was revealed that there had been persistent post-nasal dripping and rhinorrhea after that accident. And recurrent episodes of similar type of meningitis, around 5, were found in the post-traumatic period, and there was a history of fever on and off. His past treatment history revealed that he had history of multiple hospital admissions for the treatment of meningitis, and he had been under treatment for persistent rhinorrhea in ENT department, which was taken as allergic rhinitis. On gross examination of the patient, there was right marked ptosis with right exotropia and right hypotropia. His visual acuity was 6/9 in the right eye and 6/6 in the left eye. His color vision was normal on both the sides. His IOP was 10 millimeters of mercury, whereas his extraocular movement showed right superior rectus, inferior oblique, and medial rectus under action, whereas his lateral rectus and inferior and superior oblique was normally acting. His Hirschberg test shows right exotropia of 40 degree and right hypotropia of 5 degrees. His ptosis measurement in the right eye showed with a marginal reflex distance of 0 millimeters, palpebral fissure height 5 millimeters, levator function 4 millimeters, and upper lid crease at 6 millimeters. His jaw winking, bell phenomena, and fatigability were absent. His pupillary examination showed right dilated and round pupil which was non-reacting to light and accommodation, whereas his left pupil was normal and there was no reverse Marcus gun pupil. His corneal sensitivity was normal on both the sides. Under slit lamp examination, except pupil anterior segment was normal on both the sides. and his fundus examination showed that media was clear, disc and macula were grossly healthy, and no retinal pathology was seen on fundoscopy. His cranial nerve examination showed that his olfactory nerve on both the sides was involved with patient was having anosmia, and and further it shows that third nerve palsy was also there with pupillary involvement. Rest of the cranial nerves, including cranial nerve 2, were normal on both the sides. His systemic examination, including CVS, respiratory, GIT, and CNS, was normal with no peripheral or sensory or motor loss. So, on the basis of our history and clinical examination, our clinical diagnosis was dysfunctional olfactory and oculomotor cranial nerves with possible etiology of meningitis. So, our investigations for our case was to find out the cause of recurrent meningitis, and third nerve palsy was pupillary involving, so surgical cause must be searched. For that investigation we were performed was CBC, which showed increased WBC count with TLC count of 18,000. CSF was turbid in nature, having glucose of less than 40 milligrams per deciliter and protein more than 55 milligrams per deciliter. His MRI shows fracture on the cribriform plate on the left side, and the findings are most likely suggestive of the dural tear and fracture of cribriform plate on the left side, resulting in CSF rhinorrhea. So our final diagnosis on the basis of history, examination, and investigations, post-meningitis, right third nerve palsy, secondary to fractured cribriform plate was made. Treatment given by the medical department for meningitis includes injection ceftriaxone 1 gram IV BD for 14 days, injection decadron IV single dose, and injection paracetamol tablet paracetamol and tablet gravinate 1 for into TDS. Our ocular management plan include the observation of patient for recovery and occlusion of the right eye for diplopia. If the third nerve palsy persists and become chronic, plan for prism for diplopia or surgical intervention was made. Definitive management was referral to the neurosurgeon and ENT department for repair of cribriform plate. So by this case, the take-home message is that a detailed history is mandatory, and history of persistent unilateral rhinorrhea should always be taken seriously, and every effort should be made to find and rule out any treatable cause. Thank you.
Now move on to case number 2, which will be presented by Dr. Ahmed Yashar Khan. He is also third year FCPS resident in our department.
Bismillah ar-Rahman ar-Rahim. I am Dr. Ahmed Yashar Khan, third year FCPS training in Department of Ophthalmology in Gurki Trust Hospital. The case that I'm going to present today is of a 27-year-old male who's a resident of Sheikhupura. He presented to us in the OPD on the 11th of March 2024. His main presenting complaint was of marked inward and upward deviation in the left eye, which was since birth. Coming on to the present history of present illness, he had an inward and upward deviation in left eye since childhood. He was advised to undergo squint surgery at the age of 4 years, but did not get operated. There was no history of any use of glasses, there was no history of diplopia, and there was no history of any other recent illness. Coming on to the past ocular history, according to his mother, he had a trauma in the left eye with seizures when he was 7 years of age, which was followed by surgery for corneal tear, and surgery of traumatic cataract was done at the same time as well. There was no record of any repair after trauma to the left eye. The past medical history of the patient was insignificant as well. There was no history of diabetes, hypertension, or asthma. The family history was also insignificant with no history of squint. The birth history is normal as well, with him being born full term with no complications. Coming on to the gross examination, the head posture of the patient was normal and there was no facial asymmetry noted. The general physical examination of the patient was normal as well. He was well oriented in time, place, and person. While in ocular examination, his visual acuity was 6.6 in the right eye, while it was counting finger in the left eye, becoming 660 with pinhole, and his best corrected visual acuity was 624 with glasses. The color vision of the patient was normal in both eyes, and his IOP was 16 millimeter of mercury in both eyes as well. This is the orthoptic assessment of the patient. As I mentioned earlier, his head posture was normal. There was ocular deviation of the patient with left esotropia of 35 degrees and hypertropia of 15 degrees with tendency to alternate. The fixation was central in both eyes. These are the extraocular movements of the patient. As you will see that there is overaction of both inferior oblique muscles, which is more prominent in left as compared to the right eye. The convergence of the patient was normal. The Belchowski head tilt test was inconclusive. This is the slit lamp examination of the patient, and you can see that the right eye is normal. While coming onto the left eye, the cornea had a healed scar with pupil being dilated and non-directive, and him being aphakic in the left eye as well. The fundus examination was normal, while the binocular functions were grossly impaired. A non-cycloplegic retinoscopy at a distance of 1 meter revealed that he had a marked hypermetropic astigmatism in the left eye. These are his autoref findings. While the force reduction test that was done on the operating table was negative. So after going through all the history and ocular examination, we came to the conclusion that the patient had comitant left esotropia of 35 degrees with marked hypertropia, and there was tendency to alternate. Since the patient was 6'6" in the right eye, he was not willing to undergo any surgery which will involve his right eye, so he was only willing for surgery on the left eye and was concerned for full alignment. So based on all these things, I would like to respectfully ask my esteemed seniors, what will your suggestion be in this particular case, where the patient is actually 6'6" in the right eye and counting figure in the left eye, and he doesn't want his right eye to be operated on, and he only likes that we operate on his left eye and somehow try to align both of his eyes. Any suggestions from the respected seniors? What could be done in this particular case? Okay, so what Sir Shafiq thought of this was that we will perform the following plan, where we will perform the squint surgery under general anesthesia. So the plan was for left medial rectus recession, along with left inferior oblique recession and left lateral rectus plication. So during surgery, when we were doing the surgery, we started with recession of left medial rectus muscle, which was of 7 millimeter, and along with that, there was also upward transposition half breadth, and marginal myomectomy was also done. Along with that, we also did left inferior oblique recession to inferior border of left lateral rectus and left lateral rectus plication of 6 millimeter. So this is the picture of the patient on the first post-op day, and as you can see in the picture, that the full alignment of the eye has almost returned. This is the patient after 1 week of undergoing surgery. This is also another picture, and as you can see in the picture, the eyes are almost straight. So this was obviously done by Sir Shafiq, and he obviously did a good job. So since we have performed the surgery, and the main concern of the patient, which was his full alignment, was done. So what could be the further planning in this patient? Can we do something for the left eye of the patient, which was left aphakic and had a corneal scar? Can I? This is the question for the esteemed seniors. For the left eye, which had a corneal scar, and also he was aphakic in the left eye. Can we do something about that as well? The scar was, I think, central in the patient. 624 हो रही थी सर जी वैसे फिंगर काउंटिंग all right. Okay, that was the case. Thank you for your inputs. Any questions?
Thank you so much, Dr. Yashar. The next case is about a young guy who presented to us with, in the meantime, Professor Imran Akram Sahaf is here. We welcome you, sir. So the next case is about a young guy who presented to us with parents, and they said that his eyes were dancing like an angel since he was born. So we have to do something to stop the dance. To present this case, Dr. Mariam Khalid, third year FCPS resident, kindly come here.
Bismillahirrahmanirrahim. Assalamu alaikum, everyone. I am Dr. Mariam Khalid, FCPS PGR Ophthalmology in Gurki Trust Teaching Hospital. So before starting my presentation, I just want to excuse that there might be minor inconvenience during the presentation, as I have a very sore throat, so kindly cooperate. Thank you so much. Starting my presentation with the history of the patient, it was a 9-year-old male school-going child from Khanewal who presented to us with the complaints of to and fro movements of the eyeball from 6 months of age and decreased vision and head turn from 1 year of his age. This is the picture of the patient. Here you can see the head turn of the patient towards the left side. So coming to the history of his presenting illness, at 6 months of age, his mother noticed to and fro movements of the eyeball that were horizontal and continuous. Initially, the attendants were only reassured and no treatment was advised. At 1 year of age, the patient was examined again. A refractive error along with a slight face turn was noted. So glasses were prescribed to the patient, but there is no previous record available of the past examination or any treatment done, except for the glasses that he was wearing. Over the time till 9 years of age, when the patient presented to us, the degree of his head turn has increased. But the patient has no complaint of diplopia, oscillopsia, abnormal deviation of the eyes, or any other ocular complaint. A detailed systemic history of the patient was taken that was unremarkable. Regarding the birth and developmental history, the patient was born full-term by a cesarean section. There is no history of prenatal or postnatal infections, birth trauma, fever, seizures, or any neonatal ICU admission. His developmental milestones were also normal. The past medical and surgical history of the patient was unremarkable. Coming to the past ocular history, patient has been using the same prescription glasses since the age of 1 year. but there is no history of patching, ocular deviations, medical, or any surgical management done. The patient was born to non-consanguineous parents. There is no family history of early age cataracts, ocular deviations, abnormal eye movements, very high refractive errors, or any other congenital disorder. The patient has two other younger siblings, which are completely normal. Now, coming to the general physical examination, the vitals of the patient were completely normal according to his age, and the rest of the negative examination findings you can also see in this table. The ocular examination, the patient has visual acuity of 6 by 24 uncorrected in both his eyes. His color vision was normal, and visual fields done by a confrontation method were also normal. This table shows the slit lamp examination findings of the patient. Here you can see that the anterior segment and the posterior segment of the patient in both his eyes were completely normal. Now coming to orthoptic assessment, when the visual acuity of the patient was done without his abnormal head posture, his visual acuity was 6 by 24 in both his eyes, while with abnormal head posture, that is head turned toward the left side, his visual acuity improved to 612 in both his eyes. The patient has bilateral horizontal jerk nystagmus. Here in this video, you can see the horizontal jerk nystagmus in both his eyes. This is the nystagmus evaluation chart of the patient. Here you can see that the patient has null point at the right extreme gaze, while in the left gaze, the frequency of his oscillations increase. This video shows the extraocular movements of the patient being done. Here you can notice that in the left gaze, his oscillations increase, while in the right extreme gaze, his nystagmus dampens. So that is the null point of the patient. During the orthoptic assessment, it was also noted that the patient has a face turned towards the left side and null point at extreme gaze. Now coming to the cover test, a minimal alternate exotropia was noted, which can be seen in this video. On alternate prism cover test, alternate exotropia of 12 prism diopters with non-accommodating target was measured. The extraocular movements of the patient were full in all direction of gazes and there was no diplopia. This picture shows the extraocular movements of the patient. Here you can see that the extraocular movements are full in all direction of gazes. This video shows the extraocular movements of the patient being done, and you can notice that they are full in all direction of gazes. Uh, so after the orthoptic assessment, the glasses were prescribed to the patient after doing his retinoscopy. The prescription of the patient was as follows. -1 cylinder in the right eye, while -0.5 cylinder was advised in the left eye. The stereo acuity of the testing of the patient was done with abnormal head posture, and with the 2-pencil test, it was 3000 seconds of arc, and with the FITB test of 3 millimeters plate at 30 centimeters, it was 300 seconds of arc. The systemic examination of the patient was unremarkable. So on the basis of the history of the patient and the examination that we did, the diagnosis that we made was of congenital idiopathic motor nystagmus with abnormal head posture and minimal alternate exotropia. So anyone from my audience wants to contribute that what should be the management plan of the patient?
بیٹے واٹ واز یور کنسرن جب آپ نے نسٹیگمس دیکھا تو؟
سر جو پیشنٹ کا پرائمری کنسرن ایک تو یہ بھی تھا دیٹ ہی ہیز نسٹیگمس اینڈ the next thing was that the patient has abnormal head posture. His turn was
نہیں کوئی بھی نسٹیگمس کا پیشنٹ دیکھتے ہیں آپ کا پہلا کنسرن کیا ہوتا ہے؟
سر کوئی سینسری ڈیپریویشن تو نہیں ہے پیشنٹ کو جو اس کے ویژن کو امپیئر کرے؟
میں ہاسپٹل میں وہ ایمرجنسی سے لے کے تو وارڈ تک مریض جاتے تھے اس کے اوپر سی ٹی اسکین کرانے اسٹریچر پہ، تو سڑک پہ جاتے تھے تو جس کا سر بھی انجری ہوتی تھی وہ بھی سر مارتا سی ٹی اسکین تک جاتا تھا. تو ہم نے پلان کیا کہ نہیں بھی ایک روڈ بننی چاہیے جو اسموتھ ہو اور ٹھیک ہو اور سی ٹی اسکین تک بغیر چوٹ کے جائے. تو ایم ایس صاحب سے پوچھا کسی نے کہ یہ آپ نے کیوں بنائی ہے؟ کہنے لگے کہ جی جب سڑک پہ جاتے تھے ہمارے اسٹریچر ٹوٹ جاتے تھے. تو ہر ایک کو اپنا کنسرن ہوتا ہے. اس کو کنسرن ہے کہ جی سینسری تو نہیں ہے. بیٹے اس سے آگے سوچو. بیٹے دیکھو نسٹیگمس دو ہی طرح کا ہوتا ہے، کانجینیٹل اور ایکوائرڈ. جب کانجینیٹل ہوتا ہے تو ہمیں ٹھنڈ پڑ جاتی ہے کہ فکر کی بات نہیں، اور جب ایکوائرڈ ہوتا ہے تو ہماری جان نکل جاتی ہے. ٹھیک ہے نا؟ تو سب سے پہلا کون سا ہے یہ کہ از اٹ کانجینیٹل اور ایکوائرڈ. بعد میں دیکھیں گے اس کی سینسری کو اور یہ جو آپ نے ایگزامینیشن کیا. پہلے تو ہم نے یہ دیکھنا ہے کہ از اٹ کانجینیٹل اور ایکوائرڈ. ایکوائرڈ کا مطلب ہے کہ ہر طرح کے ٹیومر، ہر طرح کی مصیبتیں، ہر طرح کے دماغ میں خرابی اور یہ اور وہ جو کچھ بھی ہے. So how do you say کہ this is congenital؟
سر جو مطلب
وہ تو ایکوائرڈ بھی ہو سکتا ہے. Anybody who can tell کہ how can you say کہ this is congenital؟ Anybody؟ اس
کی
دسن دیو نا جی، سارے چودھری بیٹھے ہیں.
جس ٹائم وہ پیشنٹ اگر سویا ہو تو اس کی چیک کر لیں آسیلیشنز کو.
اچھا گڈ، دیٹ از ون. اور دیٹ از اٹ. تو اس میں تو ساری چیزیں نظر آ رہی تھیں جو کانجینیٹل میں ہوتی ہیں. پہلے آپ نے بتایا کہ یہ اس میں نل پوائنٹ ہے، ایکوائرڈ میں نل پوائنٹ نہیں ہوتا. اور اس میں کیا ہے؟
کانجوگیٹ ہے، ہاریزونٹل ہے، کسی بھی ڈائریکشن میں اس کی.
ایک منٹ اس کو ذرا وہ چلا کے دکھاؤ جہاں وہ، ایک منٹ چلتی جاؤ ٹھہرو. اور جس میں وہ ساری موومنٹ تم نے دائیں بائیں اوپر نیچے دکھائی ہیں. ہاں یہ دیکھو، دس یونی پلانر. اب ہمیں سر ماری جاتی. اس یونی پلانر کا کیا مطلب ہے؟ یہ اوپر دیکھے، نیچے دیکھے، دائیں دیکھے، بائیں دیکھے، اٹ ول ریمین ہاریزونٹل. ایکوائرڈ جو ہے وہ ورٹیکل بھی ہو جائے گا، ٹیڑھا بھی ہو جائے گا، دوسرا بھی ہو جائے گا. سو دس از یونی پلانر. اور جب یہ دور دیکھتا ہے نل پوائنٹ سے، اس کا نسٹیگمس بڑھ جاتا ہے. ٹھیک ہے نا؟ اس کو ڈپلوپیا نہیں ہے، آپ نے خود بتایا. اوسیلوپسیا نہیں ہے، آپ نے خود بتایا. یہ سوئے ہوئے ختم ہو جاتا ہے، آپ نے خود بتایا. ٹھیک ہے نا؟ یہ ساری باتیں جو ہیں دیز آر پارٹ آف کانجینیٹل نسٹیگمس. سو فرسٹ تھنگ آپ نے جو دیکھنی ہے، از اٹ کانجینیٹل اور ایکوائرڈ؟ ایکوائرڈ ہے تو پھر آپ کیا کرو گی؟
سر اس کی انویسٹیگیشنز آگے،
پھر اس کے بعد
سر پھر اس کے اکارڈنگلی میں نے
اس کو برین میں ٹیومر ہے، اب کیا کرو گی؟
وہ آگے ریفر کر دیں گے نیورو سر.
تو تم نے پہلے دن کیوں نہیں کر دیا؟ وائی ڈڈ یو ویسٹ ٹائم؟
سر
وائی ڈڈ یو ویسٹ ٹائم؟ ہارٹ کا مریض آ گیا، مر رہا ہے، میں اس کے ای سی جی بھی کر رہا ہوں، یہ بھی کر رہا ہوں، آخر میں کہتا ہوں ہاں یار اس کو ایم آئی ہے، اس کو بھیج دو کارڈیولوجی میں. وڈ دیٹ بی سین؟ اس کو آپ پہلے دن ہی اپنے سے ہٹا دو گے، آپ کا کام ہی کوئی نہیں اس میں ایکوائرڈ کے اندر. ٹھیک ہے نا؟ کانجینیٹل میں ہاں یس کم آن، آپ نے سارا کچھ دیکھ لیا. ٹھیک ہے. سو دیز آر دی فیچرز آف کانجینیٹل نسٹیگمس. ٹھیک ہو گیا؟ اب آپ بتاؤ کیا کرو گی؟ کوئی اور بتا دے. ٹھیک ہے, میں نے صرف یہ بتانا تھا کہ آپ نے پہلی چیز جو کرنی ہے وہ ایکوائرڈ اور کانجینیٹل کو دیکھنا ہے سب سے پہلے, بعد میں کچھ اور دیکھنا ہے. ہاں جی, اور بتائیں کیا کریں گے, بتائیں. اس کا پرابلم کیا ہے اس وقت؟
اس کا پرابلم ایک تو نسٹیگمس ہے.
ہاں جی,
ٹورڈز دی لیفٹ سائڈ.
ٹھیک ہو گیا, اب نارمل ہیڈ پوسچر ہے. آپ ان دونوں کو ٹھیک کرنا چاہ رہی ہیں, ان دونوں کو ٹھیک. یہ نسٹیگمس کب کم ہو جاتا ہے؟
سر اس کی ایکسٹریم گیز میں, رائٹ ایکسٹریم گیز,
نل پوائنٹ میں ہو جاتا ہے, کم ہو جاتا ہے, یا بلکہ بعض لوگوں میں ختم ہی ہو جاتا ہے. اچھا, ایک اور چیز بھی ہوتی ہے اس میں کانجینیٹل میں, اٹ انکریزز آن کانسنٹریشن. آپ اس کو کہو گے کہ وہ دیکھو سامنے کیا پڑا تو ایک دم ایسے ایسے تیز ہو جائے گا, اور جب آپ اس کو کہو گے میری انگلی کو دیکھو کنورج کرو تو وہ کم ہو جائے گا. when you tell him to converge وہ کم ہو جائے گا. جب آپ اس کو کہو گے دور دیکھو تو ایسے دیکھے ایک دم تیز ہو جائے گا. یہ سارے فیچرز ہیں کانجینیٹل نسٹیگمس کے, تو آپ کو پتا ہونے چاہیے, ہر ایک کو پتا ہونے چاہیے. چلو پھر آپ اس کے نل پوائنٹ اب کیا کرنا چاہ رہے ہیں, اپنا ہیڈ پوسچر کیسے ٹھیک ہوگا؟ شاباش.
سر سرجیکل آپشن جو ہم نے اس کو دی تھی سر, میں
ہاں بتاؤ کیا دیا تھا.
ایمز آف اے ٹریٹمنٹ انکلوڈ ریڈکشن آف improvement of his vision and to straighten his head posture.
ٹھیک ہے,
The management plan can include surgical and non-surgical options.
نہیں پہلے بتاؤ, پہلے یہ بتاؤ یہ سارا کچھ کیوں دے رہی ہو؟
This is just
اچھا, بتانے کے لیے. بیسیکلی آپ چاہتے کیا ہو, اس کا سر سیدھا کرنے کے لیے آپ کو کیا کرنا پڑے گا؟
point in the primary position.
یس, آپ کہو وی وانٹ ٹو شفٹ ہز نل پوائنٹ ٹو دا پرائمری پوزیشن, بات ختم ہو گئی. وہ کیسے ہوگا وہ بات کی بات ہے, ٹھیک ہے نا. یو شفٹ دس نل پوائنٹ ٹو دا پرائمری پوزیشن, ٹھیک ہو گیا. تو کیسے کرتے ہیں بتاؤ, آگے بتاؤ. شاباش.
So for the optical management, glasses were already prescribed to the patient, and trial of prisms can be given to such patients.
کیوں 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 یہ تم نے بیس آؤٹ پرزم کیوں دی ہے؟
Sir, we did not advise him
نہیں,
because in this case his degree.
ہم کیوں دیتے ہیں؟ چلو ایسے کر لو.
Sir,
بیس آؤٹ پرزم آپ نے لکھا نا, وائی, ہاؤ ڈو دے ورک؟
اس کا تاکہ جو اس کی جو امیج بن رہی ہے وہ پرائمری پوزیشن کی طرف شفٹ ہو.
دیٹس ناٹ دا ریزن. بیس آؤٹ پرزم آپ دونوں آنکھوں میں دے رہی ہیں تو امیج ایک طرف کیسے شفٹ ہوگا, وہ تو دو طرف شفٹ ہو گیا.
جب وہ کرے گا تو اس میں یہ جو پیشنٹس ہیں ان کی جو نسٹیگمس ہے.
گڈ, یہ تو نے ابھی سوچا یا پہلے پتا تھا؟ اگر ابھی سوچا تو اٹس ویری انٹیلیجنٹ. کنورجنس کے اوپر اس کی نسٹیگمس کم ہو جاتی ہے, سو ہم اس کو انڈیوس کرتے ہیں بیس آؤٹ پرزم دے کے, اس کی کنورجنس انڈیوس کرتے ہیں, اس سے اس کی کنورجنس جو ہے وہ کنورجنس کی وجہ سے اس کا نسٹیگمس کم ہوا. دیٹ از ون. شاباش. اور آگے چلو بتاؤ.
Surgical management plan may be a Keston-Barnes-Anderson procedure or 4-muscle tenotomy resuture procedure. In our case, what we did was Keston-Barnes procedure under general anesthesia. These were the investigations done for the GA assessment that were normal. So in Keston-Barnes procedure, what we do is we shift the null point of the patient in the primary position. The muscles which are involved in the right extreme gaze of the patient that were recessed while counter muscles were resected. So in our case, we did left medial rectus recession 5 millimeters and lateral rectus resection 8 millimeters, while in right eye, the lateral rectus recession was 7 millimeters and medial rectus resection was 6 millimeters. This is the post-op alignment of the head the patient. Here you can see that his head posture has improved. These are the post-op extraocular movements of the patient, which are completely normal, despite the resections and recessions of the muscles that we did. This is the post-op all-in-one video of the patient. Here you can see alternate cover test of the patient being done. And you can see that there is no exotropia or only a minimal exophoria. Is
कौन करता है cover test?
extraocular movements of the patient being done. Here you can see that the extraocular movements are full in all direction of gazes. This is the convergence of the patient being done. So this is a very recent picture of the patient, and it is a note of thankfulness in itself for the attending surgeon that it not only improved his nystagmus and abnormal head posture, but this surgery also resulted in improved self-esteem of the patient and improved his academic performance as well. Thank you so much.
ये सर्जन कौन था?
Professor Shafiq साहब से.
कर लेते हैं. How you assess कि किस मसल को रिसेट करना है, किसको रिसेस करना है? इन सारों ने करना होगा ना बाद में. सिर्फ इनको सुनाना तो नहीं, इनको थोड़ा सा एनलाइटन भी करना है.
जो patient का abnormal head posture was towards the left and his eyes were in right extreme gaze. So in this case, we can see that it was exodeviation of the right eye and esodeviation of the right eye. So what we do is we operate according as if the patient has right exotropia and left esotropia.
Yes. That is the easy way to sort of assess. लेकिन इसकी जो physiological है वो थोड़ा सा मुश्किल है जानना. लेकिन this is the easiest way. इसकी एक पिक्चर दिखाएंगे पहले वाली. ये सब बस यहाँ रख दो. So this is his null point. इसको बजाय इसके कि हम इसको physiologically describe करें, what we say is कि he has got a right exotropia. ठीक है ना जी? हम इसका right exotropia अपनी जगह पे ठीक कर दें without thinking about the left eye. ठीक है. उसके बाद लेफ्ट को क्या है? इसोट्रोपिया. सो इसो को लेफ्ट को हम सीधा कर दें विदाउट थिंकिंग अबाउट द राइट आई, तो दोनों चीजें ठीक हो जाएंगी. ठीक है ना. लेकिन फिजियोलॉजिकल डिस्क्रिप्शन थोड़ी मुश्किल है. अच्छा, ये जो इसके 11 पॉइंट्स हैं कॉन्जेनिटल निस्टैग्मस के, 6-7 सबको आने चाहिए. ये तो बुरी बात है, आप लोग और चक्रों में पड़ जाते हो. पहले तो देखो कि कॉन्जेनिटल है या एक्वायर्ड है. एक्वायर्ड है तो सीधा सीधा उसको भेजो जिसने डील करना है. हमारा काम ही नहीं है. ठीक है ना. थैंक यू वेरी मच.
Dr. Naila Hanif, please come here and present her case.
Bismillahirrahmanirrahim. Assalamu alaikum everyone. I am Dr. Naila Hanif, postgraduate resident, Gurki Trust Teaching Hospital. Let's start with that case. My patient, 30-year-old female resident of Gujranwala, came to the IOPD with the presenting complaint of severe headache since 2 years and decreased vision in both eyes since 6 months. Patient was all right 2 years back when she developed severe headache that was gradual in onset, global, and started early in the morning and persisted throughout the day, increased on coughing and bending forward. Headache was not responding to any medication and there was no associated history of nausea and vomiting. There was no history of flashes, scintillating scotomas, etc. And there was no history of nasal obstruction or sinuses disease. Patient also have complaint of decreased vision in both eyes, which was gradual in onset and it was not associated with redness or pain in eyes. She was already wearing myopic glasses of -2.50 dioptric sphere in both eyes for the last 2 years irregularly. In the past, patient had pregnancy-induced hypertension and she was controlled with medication, taking hypertensive medication, calcium channel blockers, ACE inhibitors, beta blockers, and post-gestationally. Patient was also having diabetes since 5 months and she was on oral hypoglycemic agents. She has the history of polycystic ovaries and amenorrhea after C-section. There was history of hirsutism and progressive weight increase. Patient also have started bone pains 5 years ago. A diagnosis of hypovitaminosis D was made, and despite adequate replacement, no improvement occurred in her symptoms. Psychologically, patient was depressed most of the times with agitated behavior and inability to sleep. She had no attempt of suicide, but she was using selective serotonin reuptake inhibitors. Socioeconomically, she was a housewife and belongs to a well-off family. So we did her gross examination, ocular and systemic examination. On gross examination, she was having buffalo hump and hirsutism. Her general physical examination was completely fine, except that her blood pressure was 170 by 100 millimeter of mercury and she was 91 kg. Her ocular examination, she is having visual acuity 612 in the right eye and 6 by 18 in the left eye. So best corrected visual acuity was 6.6 with minus 3.50 dioptric sphere. Her pupillary reactions were normal and extraocular movements were also full. Her intraocular pressure was 16 millimeter of mercury in both eyes. On confrontation, we noted bilateral temporal visual field loss, and her slit lamp examination, anterior chamber examination was completely fine. On fundus examination, bilateral discs and maculae were healthy. This is the picture of both the fundi. On perimetry done by Humphrey field analyzer, there was bitemporal hemianopia. This is the optical coherence tomography of the retinal nerve fiber layer, which is consistent with the findings and examination of the fundus. The optical coherence tomography of macula was also resembling with the findings of the fundi and perimetry. So on the basis of history, examination, and initial ocular investigation, my provisional diagnosis was space-occupying lesion at the level of optic chiasma. So we referred the patient to medical department for further evaluation. In the medicine, they noticed easy bruising of the patient, thin skin, thin extremities, and pinkish stria on abdomen. They offered a list of investigation containing hormonal profile, thyroid profile, serum cortisol, 25-hydroxy vitamin D3 level, serum ACTH level, serum insulin, RFTs, LFTs, lipid profile, ultrasound abdomen, and MRI brain. So patient's 25-hydroxy vitamin D3 level was high. Her morning and evening cortisol levels were also high. Her hemoglobin A1C was 7.9%, again high, and lipid profile was also high. Her serum adrenocorticotropic hormone was 78.10 picogram per ml. That was high. Her thyroid profile was normal, renal profile was normal, and on ultrasound abdomen, moderately increased intra-abdominal and abdominal fat noted. No ascites, no enlargement of para-aortic lymph nodes. This is the MRI brain taking axial images and with T2 and FLAIR, on which they noticed a mixed signal intensity space occupying lesion of 2.5 into 2.3 into 1.6 centimeter that was originating from the pituitary fossa, extends cranially to optic chiasma, causing its compression. So features are consistent with the pituitary macroadenoma. So my final diagnosis was adrenocorticotropic hormone producing pituitary macroadenoma. We can offer the patient two types of management. Medically, we treated her hypertension and diabetes, and surgically, we offered craniotomy for tumor removal or stereotactic radiosurgery. That could either be gamma knife surgery or cyber knife surgery. So my patient opted the option of gamma knife surgery, and she went to Karachi for the treatment of macroadenoma. This is the skull geometry, which is a preliminary investigation before doing the macroadenoma gamma knife surgery. It is done in Karachi, and these are the MRI markings of macroadenoma. After taking the treatment, patient come back to us and they followed up with us. She was, her hypertension, diabetes and hirsutism managed here in the medical department. Then post-treatment MRI was done and shows the pituitary gland appears atrophic and no new lesion identified in the cellar and paracellar area. Her post-treatment positron emission tomographic scan shows the post-gamma knife low uptake of FDG seen in the pituitary. This is the visual field done after taking the treatment. As you all can see, there is resolution of the bitemporal hemianopia. It is almost normal. This is the pre-op and post-op perimetry comparison showing before there was bitemporal hemianopia and after taking treatment, it is resolved more than 90%. Thank you so much. Sir, she was diabetic also and taking oral hypoglycemic agents. So glucophage also and prostaglandin analogs, they both used for the treatment of hirsutism.
बाइटेम्परल हेमियोनोपिया क्यों हो जाता
Uh, bec-
पिट्यूटरी तो बीच में है
because of the compression of the optic chiasm.
नहीं पिट्यूटरी तो बीच में है ना तो बाइटेम्परल हेमियोनोपिया हो गया
Yes, sir, because
अंदर वाली फाइबर अफेक्ट होती है ना तो बाहर की बाइटेम्परल क्यों हो गया अंदर की तरफ क्यों नहीं हुआ
because they cross at optic chiasm. So
ये जो अंदर वाली फाइबर्स हैं ये रेटिना के किस एरिया को रिप्रेजेंट कर रही हैं
temporal. Sir,
पीछे शफीक कितने
पता ही पीछे चला गया
मेरे शफीक
वो चले गए
अच्छा नहीं आप नहीं छोड़ो जी बैठो आप बैठ जाओ जो अंदर फाइबर्स क्रॉस कर रही हैं ये रेटिना के किस एरिया को रिप्रेजेंट कर रही हैं नेजल को या टेम्पोरल को नेजल को तो टेम्पोरल फील्ड नेजल जो रेटिना है वो टेम्पोरल देख रहा होता है ऐसे नहीं नेजल रेटिना जो है टेम्पोरल साइड पे देख रहा होता है तो फिर वही फील्ड जाएगा ना नहीं सिंपल नहीं पता होता ना यही तो मुसीबत है चलो हमने तो बहुत सादा सवाल किया था चलो कॉम्प्लिकेटेड
डॉक्टर साहब एक मिनट व्हाट इज द इंपॉर्टेंस ऑफ follow up visual fields in these patients
so to check the that either our treatment is appropriate or not, or is it progressing or resolving, there is any thing happen if we treated the patient or not, like if we have treated the patient, what is the prognosis, that's why.
चले any PG what is the importance of follow up visual field in this particular patient 3 महीने बाद 6 महीने बाद बाई टेम्पोरल हेमियोनोपिया दोबारा आना शुरू हो गया और पिट्यूटरी का साइज भी रिग्रेस्ड है वो नहीं बढ़ा थिंक सिंपल व्हाट इज एम्प्टी सेला सिंड्रोम
There is compression of the supracellular area.
No, there is no compression now. सेला तो वो तो खाली हो गया तो बाई टेम्पोरल हेमियोनोपिया दोबारा आ गया और पेशेंट परेशान है क्या इन्वेस्टिगेशन दोबारा कराएंगे और क्यों बाई टेम्पोरल हेमियोनोपिया दोबारा आ जाएगा ये लेवल 4 के पीजीज को तो आना चाहिए फेलोज से हम एक्सपेक्ट करते हैं दे आर बियॉन्ड द लेवल चलो एम्प्टी सेला सिंड्रोम तो पढ़ना ना जाके और द कियास्मा कैन एक्चुअली यू हैव अ एम्प्टी स्पेस एट्रोफी हो गई ना या आप सर्जिकली पिट्यूटरी फॉसा खाली कर दें या स्कार करके खाली हो गया ना वो तो द कियास्मा कैन एक्चुअली फॉल एंड गेट इनटू sort of a herniation जैसे इमरान साहब कह रहे हैं So the bitemporal hemianopia can start cropping up again. दोबारा आना शुरू हो जाता है. और उसकी ट्रीटमेंट फिर देन यू हैव इट्स अ बिट ऑफ अ रेयरिटी, लेकिन आपको पता होना चाहिए. तो इस पेशेंट का आप 6 महीने बाद और साल के बाद वो जरूर करवाएं. और ट्रीटमेंट फिर आप यू हैव टू हैव एक्चुअली फिक्सेशन विद अ न्यूरोसर्जन. यू कैन गो इन इंडोस्कोपी एंड दे कैन पुट इन ड्यूरोमैटर implant there to fill up the space. So this is one of the possibilities that you have to have in your mind when you're following up these patients. ये इमरान साहब के पहलू में बैठ के मुझे ये ख्याल आया.
पिट्यूटरी कितना बड़ा हो जाए तो सिम्टम्स देने शुरू करता है, फील्ड इफेक्ट आने शुरू होते हैं.
सर 5 मिलीमीटर
थोड़ा और ज्यादा कर दो.
से बिकॉज
यस अबाउट 10. इसका मतलब है अगर फील्ड इफेक्ट आने शुरू हो गए तो पिट्यूटरी काफी बड़ा हो चुका है. थैंक यू.
और आज पीजीज का होमवर्क मेरी तरफ से इमरान साहब के साथ जोड़ के, एक तो प्रोजेक्शन का कॉन्सेप्ट आपने पढ़ना और एक हॉरोप्टर का पढ़ना. थैंक यू.
ਵੀ ਪ੍ਰੀਜ਼ਿਊਮ ਕਿ ਇਹਨਾਂ ਨੂੰ ਪਤਾ ਹੈ ਬਾਈ ਟੈਂਪਰੇਚਰ ਕਿਉਂ ਹੈ. ਨਹੀਂ ਤੁਸੀਂ ਇਹ ਦੇਖੋ ਕਿ ਵੀ ਪ੍ਰੀਜ਼ਿਊਮ ਕਿਹੜੀ ਕਰਦਾ ਤੈਨੂੰ ਪਤਾ ਹੀ ਹੋਏਗਾ.
So now we move on to our guest speaker lecture. Tumors, whether benign or malignant. A beacon of hope is in the tumor management of stereo. This radiosurgery has been proved a new dawn for the management of the tumors or cancer patients, and it have proved that apart from the traditional ways of treatment, it's a very concise, precise, and to the point, non-invasive management. So we are blessed in Gurki Hospital. Member of Pakistan Society, American Society, and European Society of Clinical Oncology. So now I would like to invite Dr.
Assalamu alaikum and a very good afternoon to all the audience. Thank you very much, Professor Dr. Shafiq sir, for inviting me over for a brief talk over radiosurgery and cyberknife. So starting with cyberknife, what exactly is cyberknife? As most of you must know that cyber means digital and knife means to cut something, right? The word knife has been added to cyberknife in total as a hypothetically in order to surrogate the concept of surgery in these kind of patients in which we cannot proceed towards total excisions of the tumors or due to age limits or co-mobs, or the patient cannot get complete anesthesia or GS. So in such kind of patients, we have to have cyberknife or robotic radiosurgery treatments for eradication of benign or malignant tumors. So in Gurki Trust Teaching Hospital, we have second cyberknife robotic radiosurgery system in Pakistan, being the first one in Punjab. And Alhamdulillah, till date, we have treated 550 plus patients successfully. And these pictures, which you can see on the screen, these are our real time. We have got the latest S7 M3 series cyberknife, which is the latest model of cyberknife. You can appreciate the robotic head in which the X-ray Linux system has been installed. And on the right side of the machine, you can see the console on which the collimeters are attached. Depending on the tumor size the patient is suffering from, starting to as low as 5 millimeter to around 8 centimeter. The beauty of cyberknife is that it can treat a patient suffering from cancer starting right from the head till toe. So what exactly is cyberknife? As I've already discussed it is non-invasive robotic radiosurgery system, basically functioning on the principle of artificial intelligence, for treatment of benign and malignant tumors, particularly in the patients where surgery is not possible, either it is inadequate or the patient is unwilling. It can treat the cancers throughout the body, including the prostate, lung, brain, spine, head and neck, liver, pancreas, kidney, even nodal tumors. It can be alternative to surgery, typically in patients who haven't undergone maximum safe resection or any complex deep-seated tumors, typically in patients with age limits. So what are the main characteristics of X-rays? It basically consists of high dose single energy 6 MV X-rays. The beauty of CyberKnife is that because it does the real time, real motion in time synchronization with more than 1600 beam angles. You don't have to tell the machine that you are supposed to radiate the patient in this particular position. All of this is decided by the robot itself under the principle of artificial intelligence. The precision is submillimetric, and due to all these factors, it is able to give the maximum tumoricidal dose to the tumor and minimum to the rest of the organs, which are basically the normal tissue. CyberKnife delivers the maximum dose to the radiation directly to the tumor from virtually any angle with submillimetric precision throughout the treatment delivery system. And this is extremely important when we are radiating the tumors which are mobilizing, which are moving through with the breathing, supposedly the lung tumors, the liver tumors, the prostate tumors, in which the urine volume is changing the exact tumor location. So in these kind of tumors, the real time monitoring synchronization is happening, and the robot itself is adjusting the beam angles throughout the treatment delivery system, which is around 30 to 40 minutes per patient. So talking about the CyberKnife treatment benefits, yet again, it is non-surgical. It does not require any sort of anesthesia. It does not require any sort of surgery. No bleeding occurs. No head frame is required. It has got a very good cancer control, typically more than 90% local control. It reduces the incidence for cognitive side effects, and the treatment sessions are only 1, 3, or 5, contrary to the conventional radiation systems in which patient has to get radiation for around 5 to 7 weeks in continuous. So the patient does not have to stop the chemotherapy or immunotherapy during the treatment systems. The good thing is that you can re-radiate the patient with CyberKnife. If he or she has already been given gamma knife or conventional radiation, the CyberKnife has the beauty to radiate it because we can synchronize the motions. We can check that what typical volume of a typical tissue is getting what amount of dose. So there is a very common question, usually the neurosurgeons are interested in, that why do we prefer CyberKnife and when do we prefer CyberKnife? So if we go back in time, like gamma knife was very, very famous for the treatment of intracranial tumors because gamma can only radiate the tumors which are present in the brain, not in the rest of the body. So you can see that the above two pictures are showing you a frame which has been invasively fixed in the skull with the help of screws. This is an invasive procedure, and you can see these holes in the frame through which the gamma source comes. It gives a shot for a certain time period and then it goes away. So around 200 beam angles through these slits comes to a typical area. The the energy has been typically consolidated in this specific area, and the patient gets treated. Now, considering the fact that we claim that the world is getting itself a safer place to live in, it's becoming a safer place to live in. So gamma knife has also been shifted to a frameless mask. So we use thermoplastic mask now in gamma knife and in CyberKnife. The beauty of CyberKnife is that we can radiate the patient with more than 1600 beam angles. I think there is some issue with the mic, I think. Okay. So we can radiate the patient with more than 1600 beam angles, typically coming from anywhere, any 360 degree, all around the six angles of position. Do you want to check it? कुछ इशू है इसमें, आवाज बंद हो रही है बार बार. हाँ नहीं वो चल रहा है लेकिन ऐसा लगता है आवाज मेरी अपनी शायद ऊपर नहीं चल रही. थैंक यू. थैंक यू. So coming back to the point that we can radiate the patient with more than 1600 beam angles, which are quite a lot in number as compared to 200 beam angles in gamma knife. So these are the main sites we are treating with CyberKnife, starting from intracranial tumors to head and neck tumors, lung, breast, spine, liver, pancreas, kidney, gynecological tumors, prostate. Along with it, we have been able to treat, alhamdulillah, functional disorders like trigeminal neuralgias. We have been radiating the ventricular arrhythmias, and soon we will be starting, inshallah, the radiation for OCDs, Parkinson's, and epilepsy disorders as well, inshallah. So I would like all of you to go through a video which will help you understand how does the CyberKnife treat the brain tumors. I'm going to play it and I hope you enjoy this video.
Treating tumors in the brain with radiation requires the most accurate approach available. The primary objective is to focus high doses of radiation to the tumor with extreme precision, directing radiation only to the tumor while protecting highly sensitive brain tissue and vessels. Introducing CyberKnife, the first and only robotic radiosurgery system that uses advanced imaging and tracking technology to continually verify the tumor, correcting and adjusting for even the slightest movement. Because of CyberKnife's unique robotic movements and pinpoint accuracy, no head frame is required in the treatment of brain tumors, allowing the patient to rest comfortably and breathe normally. Conventional systems like Gamma Knife require a rigid head frame, fastened to the patient's skull with screws to reduce movement during treatment, a painful procedure that can require anesthesia. The head frame further limits the Gamma Knife's capabilities to one single high-dose radiation treatment. CyberKnife's pinpoint precision eliminates the need for a painful head frame. Certain brain tumors show a more positive response from 2 to 5 treatments, which only CyberKnife can provide. When faced with sensitive brain conditions, CyberKnife gives our physicians the flexibility to offer a single treatment or 2 to 5 treatments. CyberKnife's unique robotic design, coupled with its advanced tracking and imaging technology, further allows your doctor to approach the tumor from the most advantageous angle possible. Without an invasive head frame, CyberKnife becomes a full-body radiosurgery system. The sub-millimeter accuracy with which CyberKnife delivers radiation to brain tumors can be applied to tumors of the head and neck, spine, lung, prostate, liver, pancreas, kidney, and more.
I hope you enjoyed the video.
Treating tumors in the brain with radiation requires...
So now coming to the side effects of CyberKnife, I won't say that there aren't any side effect, but as compared to the conventional radiation, the data has shown that around 5 versus 30% acute side radiation side effect, only less than 5% patients amongst these patients suffer from typically high intracranial pressure symptoms, which are mostly nausea, vomiting, headache, on and off orthostatic hypotension, and seizures. But these are easily manageable. And the patient, the good thing is that patient is just discharged on the same day of treatment. Now, typically coming to the role of CyberKnife for radiosurgery in ophthalmology, the international stats show that the American Cancer Registry shows that for the date 2024, there were around 3,300 new cancer patients of the eye, amongst which 1,700 were men and 1,500 were women, and about 560 deaths from eye and orbital cancers occurred amongst them. If we come to the national statistics, this is data from Pakistan Cancer Registry 2022. Around 2,200 patients were diagnosed with ocular or eye tumors and 220 amongst them died. I'm sure this data isn't the actual one because only our esteemed institutions like in Mol, Shaukat Khana, Mal Shifa, only these hospitals maintain their cancer registries. The rest of the hospitals usually don't do that. Coming to the Gurki Trust Teaching Hospital robotic radiosurgery ophthalmology stats, till date, as I already told you, that we have treated around 550 patients, and amongst them 146 were eye tumors. around pituitary, we have treated around 70 pituitary adenomas, both functional and non-functional, 55 optic nerve meningiomas, optic nerve gliomas, choroid melanoma, bilateral retinoblastoma, and jet ocular metastasis also. So these are some real-time patient pictures. You can see this is a patient of pituitary adenoma. We were able to save the vision because it was abutting the optic chiasma, but it wasn't involving the optic chiasma. So we were quite enough able to save the vision of this patient. We radiated this patient around 2000 centigrade. This is yet again another patient suffering from optic nerve glioma. Unfortunately, this patient did not have a vision in his left eye. So our primary intent of treatment was only to decrease the size of this tumor, and it wasn't to save the vision. But yet again, we radiated this patient in 2500 centigrade. This is a very interesting case. This was a kid around 5 years of age, and this was astrocytoma grade 1, and it was only abutting the optic nerve, and we were quite able to save the vision in this particular patient. So this is another interesting case. You can see this is a choroid melanoma case. The size was around 1 into 1.5 centimeter. The patient had mild vision loss in this eye. We were able to save the retina. We were able to save the orbit. And the only dose which the retina received was 7 gray, and the dose delivered was around 4000 centigrade to this typical patient. Yet again, this is a patient who was suffering from celiac breast, and she had a huge retroauricular met. And this patient was fortunate enough that she had complete remission, complete response after stereotactic radiosurgery. This is another case of sphenoid wing meningioma. Optic nerve was fully, optic chiasma tumor, and the size of the tumor was also huge, around 7.3 centimeter. This is yet another very interesting case of arteriovenous malformation of right frontal lobe, and this patient is also in complete response right now, and the size of this AVM was around 3 centimeter. So just some unique cases we have been able to treat on our CyberKnife in Gurki Trust Teaching Hospital till date. We have treated around 8 to 9 trigeminal neuralgias, lots and lots of AVMs, glomus tympanicums, carotid body tumors. We'll soon be starting radiation for epilepsy, OCDs, Parkinson's, alhamdulillah. And we have already done lots and lots of hilar meds, lung, which are basically the lung metastasis, liver metastasis, and we'll be starting radiation for ventricular arrhythmias in December soon, inshallah. So now the question comes that how accurately, how does the CyberKnife work so accurately? So there's another video clip for all of you to watch. I'll play it.
The CyberKnife system leads SRS and SBRT innovation. Its unique architecture and a linear accelerator mounted on a 6-axis robotic manipulator enables unmatched precision and versatility anywhere in the body. The patient workflow starts with a CT acquisition, the primary image for treatment planning. Digitally reconstructed radiographs are then generated by the CyberKnife system. These are virtual projections at a 45-degree angle, perpendicular to the patient couch. Transferred to the treatment delivery software, they are later used as references for pre-treatment patient positioning and real-time motion tracking and correction. The CyberKnife system's fully integrated image guidance system aligns the virtual projections to X-ray images taken prior to treatment delivery for patient positioning and continually during treatment delivery for automatic beam correction. The CyberKnife system uses specialized tracking algorithms to track the skull, the spine, fiducials, or the tumor itself, depending on the target location. For lung tumors, the X-Site lung tracking algorithm can distinguish the tumor from the surrounding lung tissue. For tumors that move with respiration, the Synchrony respiratory tracking system monitors the patient's breathing motion in real time with an optical camera and LED markers placed on the patient's chest. Before initiating treatment delivery, the system automatically acquires a series of rapid X-ray images that represents the entire respiratory cycle, Combined with the breathing motion captured with the optical camera, the system builds a personalized correlation model that predicts the tumor location and motion. During treatment delivery, the system automatically acquires additional X-ray images, continually validating and updating the correlation model. The images and the model are carefully monitored by the clinical team via the treatment delivery software intuitive display. The Synchrony respiratory tracking system tracks and corrects to the moving tumor with sub-millimeter precision as the patient breathes normally, avoiding healthy tissue. The Incise multi-leaf collimator shapes the beams to efficiently and precisely deliver the treatment. Fixed circular collimators and the iris variable aperture collimator are also available, providing the versatility needed to treat a wide range of clinical indications, from trigeminal neuralgia to large liver tumors. The CyberKnife system architecture enables the delivery of treatment beams from hundreds of potential non-coplanar and non-isocentric angles around the patient. These beams are optimized during treatment planning with a powerful inverse planning algorithm to maximize dose coverage and spare organs at risk and normal tissues. The CyberKnife system is the only radiation therapy device that maintains sub-millimeter precision with continual image guidance and automatic beam delivery correction anywhere in the body.
I hope this video was useful. So in nutshell, what CyberKnife actually does is that it has excellent long-term cancer control. It does not require any sort of surgery, no hospitalization, no anesthesia. It has only 1, 3, or 5 radiation treatments, and it has as less as 5% side effects. Thank you so very much for your kind attention. And now I would like all of you to have a visit around our CyberKnife department. And if you have any questions, you're most welcome to ask. Yes, sir.
अस्सलाम वालेकुम आई एम डॉक्टर एजाज भट्ट ये सवाल स्पेशली डेडिकेटेड है अपने उस्ताद मोहतरम साहब के लिए मैडम ये बड़ा एक्यूरेट है डेफिनेटली ये मशीन लेकिन हमारे आई में जो है वो सब मिलीमीटर प्रिसीजन से ज्यादा प्रिसीजन की जरूरत नहीं होगी क्या
सर आप बिल्कुल ठीक कह रहे हैं जो मैंने अभी आपको एक केस दिखाया था कोरोइड मेलानोमा का
जी
हमने अपने आई डिपार्टमेंट वालों से बड़ी हेल्प ली थी उसको हमने 5 फ्रैक्शंस में रेडिएट किया था और वो हर फ्रैक्शन में रिट्रोबल्बर ब्लॉक लगवा के जाता था इनसे तो इतनी ज्यादा एक्यूरेट है ये
बट द मशीन इज सेइंग दैट इट इज वर्किंग सब मिलीमीटर प्रिसीजन हमारे आई में तो मेरा ख्याल है सर आप कुछ कमेंट्स करेंगे इस वाले से प्लीज
You showed a few pictures of optic nerve glioma and optic nerve meningioma. So what we are, as an ophthalmologist, what we are concerned is the vascularity of the optic nerve and the optic nerve sheath and the pia and the arachnoid. So when you're radiating one, I would like to know that as a student, what happens to the tissue? You know, what does it convert into plasma or what? How does it actually finish off? One, and secondly, when you're working on that, how do you protect the vascularity at that microcirculation level?
So the first of all thing is that this data is like 10 to 15 years old. Lots and lots of researches have been done. And now we know that a typical amount of tissue, like for optic chiasma, we have to see as low as 0.5 cm cube. That what amount of dose, this much point dose, we call it point dose, that what point dose, a typical amount of tissue starting from extremely small chunk of the tissue to the maximum tissue which is getting radiation, how much dose it is receiving. We get the bracket, we get the numbers for as low as 0.5 cm cube. If those are not breaching, if we are within the safe range, if we are not breaching the dose limits, or we are not radiating as high as the acute side effects might manifest, so it is safe to radiate the patient. Plus, another question was that how do we ensure that the microvascularity of a certain tissue is saved? So usually it has been seen that the radiation tolerance for the vessels is quite high. Even for the nerves, it's quite high. We usually think that the nerve fibers are so intricate, they're so delicate, that even if the neurosurgeon tries to attempt the surgery, the patient might end up in vision loss, or it might end up in harm to the optic nerve or optic chiasma. So that is the beauty of radiation, that because radiation has got a higher tolerance in these kind of tissues, and we can particularly save this. So there is a very important role of like neuroradiologist in here. He has got lots and lots of responsibility, because he is the one who is actually verifying the markings. He's the one who is verifying the contours, that this is the typical tissue, this is the optic chiasma, we are supposed to save it. For instance, if there is a tumor, like it supposedly there is a pituitary adenoma, and it is properly engulfing the optic chiasma. We are not sure that where exactly the optic chiasma is. It isn't abutting it. It isn't pushing it. It has literally engulfed the whole. Now is the point that we have to decide that whether are we supposed to save the life of the patient or the vision of the patient. Now the decision comes, but the patient has to make the decision that what is he going to do. This is where the high risk consent comes. So we have to tell each and everything to the patient. जी सर.
अच्छा, आपने कहा कि ये एक्सरेज हैं, तो आर दे कॉलीमेटेड और फोकस्ड? जब आप बीम देती हैं वो पैरेलल रेज होती हैं या वो फोकस्ड होती हैं?
नॉन कोप्लेनर सर, यही डिफरेंस है हमारे कन्वेंशनल में और साइबर नाइफ में. कन्वेंशनल में सपोजिटली अगर बीच में एक ट्यूमर रखा हुआ है, तो मैंने अपनी मशीन को बताना है कि आपने एक आर्क लगानी है, आपने इस रोटेशन में मशीन ने घूमना है, और हर रोटेशन से इतने मॉनिटरिंग यूनिट्स ऑफ रेडिएशन आपने इसको देने हैं, ताकि कंसोलिडेटिव डोज मुझे जितनी रिक्वायर्ड है, सपोजिटली एक्स नंबर ऑफ मॉनिटरिंग यूनिट्स रिक्वायर्ड है, वो उधर कंसोलिडेट हो जाएंगे. साइबर नाइफ की ये ब्यूटी है कि मैंने मशीन को नहीं बताना है कि तुमने किस एंगल से जाके पेशेंट को रेडिएट करना है. इफ आई वांट टू लेट से मैं उसकी आईज सेव करना चाहती हूँ, मैं चाहती हूँ कि उसकी आंख से बिल्कुल कोई रेडिएशन ना गुजरे, मैं मशीन को बता दूंगी कि ये आपका पैसेज बंद है, आपकी आई से कोई बीम नहीं गुजरेगी, या कॉकलिया से कोई बीम नहीं गुजरेगी. बाकी उस मशीन का काम है कि वो बेशक पाँव से रेडिएशन दे या वो कमर से रेडिएशन दे, या जहां से भी दे. मेरी जो मैक्सिमम है, अभी मैं अब सिस्टम पे चलते हैं, मैं आपको दिखाती हूँ कि जो मेरा डी मैक्स डोज मैक्सिमम होगा वो विद इन 3 to 5 सेंटीमीटर से आहिस्ता आहिस्ता, सॉरी सेंटीमीटर कह रही हूँ, मिलीमीटर से मैक्सिमम वो डोज के अंदर कंसोलिडेट करेगा, और एज फार एज मैं उसकी आइसोडोज लाइंस पे पेरिफेरी में जाऊंगी वो डिक्रीज होता जाएगा. इसका मतलब है कि वो थाउजेंड्स ऑफ नॉन कोप्लेनर बीम्स हैं जो जहां से टिपिकली गुजर रही हैं जिस टिश्यू से, वो इतनी कम एनर्जी की है कि उस ट्रेवर्सरी में कोई डैमेज कॉज नहीं कर रही, लेकिन वो जहां बीच में कंसोलिडेट हो रही हैं वहां वो ट्यूमर को किल कर रही हैं.
आपकी बीम जो है एक वक्त में एक तरफ से आती है, दूसरी दफा दूसरी तरफ से, ठीक है, और वो ट्यूमर को पार करके भी गुजर जाती है.
इतनी होती है कि वो ट्यूमर के अंदर रह जाती है, पार कुछ नहीं करती, क्योंकि वो इतनी लो एनर्जी होती है.
अरे नहीं, पूरे दिमाग में से तो गुजर गई, तो ट्यूमर में कैसे खत्म हो गई?
सर वो हर जो रे आ रही है ना, वो लो डोज है. यही
हाँ, ये बात है ना, ये बात है, लेकिन ये आप कहें कि पार नहीं करती, ये नहीं हो सकता,
क्योंकि वो डिपॉजिट हो जाती है ना सर.
हाँ ठीक है,
कि वो पेरिफ्री पे ऐसा नहीं है कि वो 0% डोज देगी पेरिफ्री को, लेकिन वो अराउंड मिनिमम
सेफ होगी, सेफ होगी. सर ने पूछा था कि ट्यूमर को होता क्या है?
रेडिएशन का जो प्रिंसिपल है ना, ये बेसिकली जाके उसके डीएनए को डिस्टर्ब करती है.
ठीक है,
जब उसका डीएनए डिस्टर्ब हो जाता है, जब सेल अपना, यही फर्क है कि बेनाइन और मेलिग्नेंट ट्यूमर्स के अंदर, जो बेनाइन ट्यूमर्स होते हैं उसमें जो हमारी इंटेंट ऑफ रेडिएशन होती है वो कभी भी नहीं होती कि ये गायब हो जाएगा. वो ये होती है कि या तो ये साइज स्टेबल रहे, या अगर ये पेशेंट बहुत अच्छा रिस्पॉन्स करता है तो इट शुड डिक्रीज इन साइज. अब होता क्या है कि जब वो डीएनए उसका डिस्टर्ब कर देती है, बेनाइन ट्यूमर्स टेक years टू डेवलप, राइट. तो जब वो अपने माइटोटिक फेज में जाएगा, क्योंकि उसका डीएनए ऑलरेडी खराब है, तो वो सेल को वहीं से डिस्टर्ब करना शुरू करेगा. और इस दौरान चूंकि बेनाइन लीजन्स के जो स्टैटिक फेज है उनका, जो एस फेज है उसका वो बड़ा प्रोलॉन्ग्ड है, उसका वो इतना है ही नहीं, तो उसने कई साल में जाके उसका साइज छोटा करना है। और हमारे पास जो फॉलो अप पे आएगा एज फार एज इट द लीजन साइज इज स्टैटिक, दैट इज अ गुड थिंग फॉर बीइंग अ रेडिएशन ऑन्कोलॉजिस्ट। कॉन्ट्रेरी टू द मैलिग्नेंट ट्यूमर्स, उसमें मेरी इंटेंट ऑफ ट्रीटमेंट ये है कि चूंकि उसके सेल्स बहुत एक्टिवली डिवाइड करें, इट शुड डिक्रीज इन साइज।
नहीं, ये किसको अफेक्ट करता है? डीएनए को करता है या नेक्रोसिस करता है? ये भी
डीएनए करेगा, मॉर्फोलॉजिकली आपको नेक्रोटिक टिश्यू नजर आएगा।
अच्छा,
आप जब एमआर उसका कराएंगे 4 मंथ्स, बहुत सारे जैसे ग्लायोमास होते हैं, मेनिंजियोमास, इनका सेंट्रली नेक्रोटिक आप एप्रिशिएट कर सकते हैं, लेकिन जो बेसिक प्रिंसिपल है वो डीएनए,
वो डीएनए है, उसको चेंज करना,
उसको डिस्टर्ब
ऑन्कोजीन और उन सारों को अफेक्ट करना, बिल्कुल ठीक हो गया।
जी सर, जी सर।
सर ने जो सवाल किया ना कि ये पेनिट्रेट करके क्यों नहीं गुजर जाता, मेरा ख्याल है ये जब आप फोकस करते हैं उस लीजन के ऊपर तो दे आर कन्वर्जिंग एट दैट पॉइंट,
ऐसे ही होता है ना सर, मैं
दे आर कन्वर्जिंग एट दैट पॉइंट, वो एक सेंटर में जाके कन्वर्ज करती हैं सारी।
ये देखिए, मैं
नहीं, कंसोलिडेशन और चीज है, ये कन्वर्जेंस और चीज है, ये सारी रेज दे आर नॉट पैरेलल रेज।
नॉन कोप्लेनर, ये देखिए मैं आपको एक पिक्चर दिखाती हूँ, ये काफी कुछ क्लियर कर देगा। ये मेरी बिल्कुल ये देखें, ये
वो डोज है ना उसकी, दे आर कन्वर्जिंग एट दैट पॉइंट, वो सेंटर पे जाके उसके फेड होते
है, बिल्कुल नॉन कोप्लेनर है, वो एक जगह पे सारी की सारी कंसोलिडेट हो जाएंगी। और जो पेरिफ्री का है उसको इतनी कम डोज मिलेगी कि वो उसकी वो जो डोज टॉलरेंस है वो उसको कभी भी ब्रीच नहीं करेगी। अगर कभी ऐसा होता है, सपोजिटली, ऐसा नहीं है कि आप पहले ही प्लान बनाते हैं तो पहले ही प्लान आपका अप्रूवल के काबिल होता है। कई सारे प्लान्स टिपिकल पेशेंट्स के लिए, खासतौर पे जो ट्राइजेमिनल न्यूरैल्जियाज होते हैं, वो ब्रेन स्टेम के इतना पास रखा हुआ है कि उसको सेव करना ब्रेन स्टेम को। ट्राइजेमिनल न्यूरैल्जिया में हम 6000 सेंटीग्रेड दे रहे थे, विच इज क्वाइट अ डोज। अगर वो थोड़ी सी भी हिल जाए तो आप ब्रेन स्टेम में टिपिकली खत्म हो जाएगा वो तो उसके अंदर फिर ये कि हम ब्रेन स्टेम को और जो बाकी ऑर्गन्स एट रिस्क होते हैं उनकी हम वॉल्यूम बेस्ड डोज निकाल रहे होते हैं कि इस वॉल्यूम को कितनी डोज मिल रही है। अगर वो परमिसिबल लिमिट में, एंड दैट इज डिफरेंट फॉर 1 फ्रैक्शन, 3 फ्रैक्शंस, 5 फ्रैक्शंस, उसके अंदर भी है कि आप इतनी दे सकते हैं, दिस इज द थ्रेशोल्ड। अगर आप इससे ज्यादा देंगे तो यू आर नाउ एमिनेबल टू सी द साइड इफेक्ट्स इन सच काइंड ऑफ पेशेंट्स। तो उसके अंदर भी 2 डोज लिमिट्स हैं, प्रेफरेबली आपने जो लोअर डोज लिमिट है उससे नीचे रखना। एनी अदर क्वेश्चंस? चलो जी सर।
Ma'am, thank you very much for nice presentation and very informative for all of us. I am Brigadier Shahid, HOD CMH Lahore, I department. अच्छा, जो सर ने, प्रोफेसर आमिर ने जो जिक्र किया, अगेन माय कंसर्न इज फॉर ऑर्बिटल ट्यूमर, व्हाट इज योर एक्सपीरियंस टू सेव द विजन ऑफ पेशेंट? फॉर एग्जांपल, the optic nerve meningioma, that is very vascular tumor, and if we operate at time, we need to do embolization before surgery and then we go for the surgery. But what about once you are doing, of course there is no such thing.
बिल्कुल।
So, and secondly, what are the chances of hemorrhage post procedure, retroorbital hemorrhage? Are there chances? What is your experience, please?
मैंने कोई मेनिंजियोमास अभी तक कोई 50 के करीब किए हैं, ऑप्टिक नर्व मेनिंजियोमास। Not even a single patient has presented with post-interventional hemorrhage.
डॉक्टर आयशा, आपके पास स्फीनोइडल रिज मेनिंजियोमा की एक पिक्चर थी, वो दिखाइए जरा।
अच्छा सर, इसमें जब हम रेडिएट करते हैं ना तो हमारी इंटेंट ऑफ रेडिएशन है कि अगर पेशेंट की बेसलाइन विजन सेव्ड है तो उस तब तो रेडिएशन का भी बेनिफिट है, क्योंकि ये देखा गया है कि अगर कोई पेशेंट प्रेजेंट ही विजन लॉस के साथ कर रहा है तो दैट इज ऑन्कोलॉजिकल इमरजेंसी, कि आप उसके ट्यूमर को जितना जल्दी हो रिसेक्ट करें, क्योंकि रेडिएशन का जो डाउन टाइम है वो 4 महीने से शुरू होगा। ऐसा नहीं है कि वो कोई जादू की छड़ी है हम कर देंगे तो पेशेंट का विजन सारा ठीक हो जाएगा। उसको कम से कम पहला फॉलोअप ही 4 महीने के। अगर कोई ऐसा रिस्की केस है तो उसको हम इन द बेस लाइन ही बुक नहीं करते रेडिएशन के लिए, वो पहले सर्जन के पास जाएगा, एक्यूट डीकम्प्रेशन करवाएगा, फिर आएगा। दूसरी इंपॉर्टेंट बात ये कि जब अगर कोई पेशेंट का ऑप्टिक नर्व मुझे पता है कि ये इसको एबट कर रहा है, इट इज नॉट इन्वॉल्विंग, तो उस केस में वो मेरे लिए क्रूशल है कि मैंने उसके ऑप्टिक नर्व को सेव करना ही करना है। और वो बहुत सारे ऐसे केस बिल्कुल लैटरल या मीडियल होता है, लेकिन इट इज नॉट एक्चुअली इन्वॉल्विंग द ऑप्टिक नर्व। तो उन केसेस के अंदर फिर होता है कि कई दफा पेशेंट्स आते हैं कि जिनका ट्यूमर आहिस्ता आहिस्ता रिजॉल्व करता है, तो ये दे शो अप विद इंप्रूव्ड विजन एक्चुअली।
Thank you. Second query is your experience or for regarding invasive fungal infection, because at time patient come to us with invasive fungal infection involving the orbits and the brain, of course originating from the sinuses.
इन्फेक्शन के ऊपर रेडिएशन ने कुछ नहीं करना, इट वोंट डू एनीथिंग।
Thank you. Thank you.
जी सर, दैट इज इट।
Thank you so much.
Thank you so very much, Dr. Aisha. It was a really very nice presentation. Now the scientific session with this come to end, and I like to ask Dr. Nasir Chaudhary, sir, please come here for further proceedings.
Thank you very much, Dr. Aisha, for your innovative lecture and words of wisdom. We can witness paradigm shift from discipline-based and patient-based curriculum to, in fact, interdisciplinary, interprofessional, and student-based curriculum. So I think these sorts of collaboration between like ophthalmology and cyber nerve will definitely improve patient safety and patient care in certain cases. And this cyber knife and robotics can be a way forward in many cases. जिस तरह एजाज भट्ट साहब बात कर रहे थे उसकी मिलीमीटर की और इससे नीचे की सब मिलीमीटर, अब जो रोबोटिक्स में जो एज रिगार्ड्स ऑप्थेल्मोलॉजी 2 रोबोटिक सिस्टम काम कर रहे हैं, वन इज विंस्ट्री across United States and one is Iris that is across UK. अब उस रोबोटिक्स के पीछे जो कॉन्सेप्ट ये था, आप ILM की थिकनेस जो होती है दैट इज 50 माइक्रोमीटर, आपका जो ह्यूमन आर्म है उसका एम्पलीट्यूड ऑफ ट्रेमर है दैट इज 100 माइक्रोमीटर करीब। और जब आप ILM फील करेंगे तो ऑफ कोर्स ह्यूमन कॉम्पिटेंसी मैटर, तो जब वो बेसिकली इस जो एम्पलीट्यूड ऑफ ट्रेमर को कम करके इसको प्रिसीजन ऑफ ILM फील को बेहतर करना चाह रहे हैं। ठीक है, तो सो cyber knife and this robotic surgery can be way forward in many instances. And meanwhile, I am grateful to Professor Dr. Imran Sahab Sahab, Professor Hamid Bhatt Sahab, Professor Humaira, Dr. Sara Ijaz Bhatt Sahab for sparing their valuable time. And I would like to congratulate Professor Mia Shafiq Sahab for the excellent and quality presentations in terms of content, cognitive load, and variety of cases. Although it was a nail-biting experience, and to select which one is the more appropriate candidate for patient. And in this case, I would like to invite Brigadier Shahid Tariq Sahab. He is an eminent ophthalmologist with area of interest in oculoplasty, an excellent human being, and he will come and announce the positions of today's presentation.
Worthy senior teachers, senior ophthalmologists, my colleagues and trainees, it's really pleasure to be here. Professor Shafiq sir, thank you very much for very nice and informative this session. I am a student of Professor Akram Saaf and Professor Hamid Bhatt. Probably they may not be knowing, but through OSP conferences 20 years back, I have been your student and still I am your student, sir. Sir, thank you. So regarding the presentations, all 4 presentations were very good. Definitely we all enjoyed, very informative. And I think once you present the case, you are winner. Everyone who is presenting is the winner. Okay. But regarding decision of our worthy judges, we have to announce 3 positions. The third position goes to please come in. Okay. The second position goes to Dr. Ahmed Yashir Khan, Management of Complicated Squint. And then the first position goes to Dr. Naila Hanif, Pituitary Macroadenoma Management. So congratulations to all four of you from my side.
थैंक यू वेरी मच सर. अच्छा, अब क्योंकि स्टेज पे जगह काफ़ी है तो मैं खुले दिल से चाहूँगा कि हमारे जितने वर्दी टीचर्स हैं इधर आ जाएं. प्रोफेसर अहमद भट्ट साहब, प्रोफेसर इमरान साहब, सारे प्रोफेसर सलीम अख्तर साहब इधर. जगह क्योंकि काफ़ी है. हाँ जी, पांचों के राजे सब जगह काफ़ी. हाँ जी सर, आप आ जाए, जगह काफ़ी है सर, इसलिए मैंने सबको बुला लिया. हाँ जी सर, फिर आप इस तरह करें, राना साहब आ जाएं, आसिफ साहब और सलीम अख्तर साहब आ जाएं, काइंडली आप आ जाएं. नहीं इनको बुला लेते सर, इनको भी बुला लेते. आ जाए सर, आ जाए. प्रोफेसर मियां शफीक साहब के होस्ट है तो आप भी सर तशरीफ ले आए. तो सबसे पहले तो मैं रिक्वेस्ट करूंगा, हमारी जो गेस्ट स्पीकर थी डॉक्टर आयशा, उनको शील्ड और सर्टिफिकेट दिया जाए. हाँ आ रही यार, जल्दी करें. हाँ हाँ, ये बारी बारी हमारे टीचर्स प्रेजेंट करते रहेंगे क्योंकि चार और भी प्रेजेंटर हैं. खलील साहब और ब्रिगेडियर साहब आप भी आ जाएं. खलील साहब. अच्छा, अब जो फर्स्ट प्रेजेंटर, जो उसके लिए क्लैपिंग जो हो जाए, फर्स्ट प्रेजेंटर, उनके लिए शील्ड और सर्टिफिकेट. जो फर्स्ट पोजीशन जो फर्स्ट पोजीशन होल्डर है उसके लिए हमारे कैश अवार्ड भी होता है. तो सो उस सर्टिफिकेट के साथ कैश अवार्ड भी है. जो सेकंड पोजीशन के लिए अहमद किधर हैं जी? हाँ, सेकंड पोजीशन. इनको भी शील्ड, सर्टिफिकेट और कैश. ये सीखा है रात में. अच्छा, अब थर्ड पोजीशन के लिए जी अगेन सर्टिफिकेट, शील्ड. अलीमा आजम आ गई वो. अब जो फोर्थ प्रेजेंटर था, फोर्थ प्रेजेंटर के लिए भी शील्ड और सर्टिफिकेट है. जी जी. अच्छा, एंड में कंपनी के हमारे जिनकी बदौलत हमें एक जबरदस्त किस्म का लंच मिलने वाला है, तो उनका एक तो शुक्रिया अदा करते हैं, उनके लिए सर्टिफिकेट. अच्छा, अब क्योंकि प्रोफेसर मियां शफीक साहब ने बड़ी ज़बरदस्त किस्म की माशाल्लाह एक मीटिंग अरेंज कराई विद एक्सीलेंट का जो सेशन है, तो हमारे जो टीचर्स हैं मैं उनसे रिक्वेस्ट करूंगा मियां शफीक साहब को बोके पेश किया जाए। जी, नहीं नहीं हाँ, अच्छा अच्छा, बाकी वी आर रियली ऑनर्ड के प्रोफेसर अहमद भट्ट साहब हमेशा हमारे साथ होते हैं, प्रोफेसर सलीम अख्तर साहब भी, प्रोफेसर नजीर राज साहब, प्रोफेसर खलील राना साहब भी अक्सर तशरीफ लेके आते हैं। एक मौके हमने सर को इमरान अकरम साहब सबको इसलिए पेश करना है कि वो तशरीफ लाते रहे। आज उनके नहीं, ये वो उनका था ये एक आपने बोके जो है वो ब्रिगेडियर शायद तारक साहब के लिए संभाल के रखा हुआ था, हमारे आज के गेस्ट ऑफ ऑनर भी हैं, तो एक इनके लिए एक बोके मैं टीचर से रिक्वेस्ट करूंगा कि ब्रिगेडियर शाहिद साहब को एक बोके पेश किए। इसके साथ ही मेरा ख्याल है कि वो काम खत्म हुआ और अब लंच के लिए लंच रेडी है। और थैंक यू वंस अगेन हुडसन, आप लोगों का, अबू बकर और आपकी पूरी टीम का, और रिजवान भी इधर मौजूद है, तो अब लंच के लिए आ रहे सर। थैंक यू।
मैं आप अपने तमाम उस्ताद का बेहद मशकूर हूँ। राना साहब, आसिफ साहब, सलीम अख्तर साहब, अहमद साहब मेरे क्लास फेलो भी हैं और मेरे उस्ताद भी हैं और बहुत बड़े उस्ताद हैं, और साहब इसी तरह शाहिद, सबका मशकूर हूँ। आप सबका भी जो आप यहाँ पे बैठे, और मैं रियली थैंकफुल टू डॉक्टर आयशा, आपने मेरे एक लफ्ज़ के ऊपर प्रेजेंटेशन दी, थैंक यू। और अपना अबू बकर, आपका बहुत शुक्रिया। इट वाज नाइस गैदरिंग फ्रॉम ऑल ऑफ यू। और आपके लिए अब खाना तैयार है, लेकिन रुकावट सिर्फ एक है और वो साइबर नाइफ है। अगर आप शॉर्ट विजिट साइबर नाइफ का कर लें तो यू विल रिमेंबर इट ऑलवेज। तो अब हम यहाँ से साइबर नाइफ डिपार्टमेंट जाएंगे 5 से 10 मिनट में, वहाँ से कैफेटेरिया खाने के लिए। थैंक यू।